I'm Todd Stryak with Medical Economics, and I'm here with Dr. Colin Banas, the Chief Medical Officer at DrFirst. Doc, thanks for joining me.
Hey, thanks so much for having me.
So, let's talk about medication adherence. How big of a problem is this currently?
This is a big problem. I mean, pick your number, but most estimates put this at close to a $500 billion problem for the U.S. health system. You know, at Dr. First, we're fond of quoting a statistic related to first fill not getting picked up for a medication. It's over 25%. So one in four prescriptions that I write as a physician won't get picked up by my patient. And I might not ever figure that out until the patient comes to see me again, which could be 6 to 12 months later. And, you know, what happens is I've lost a lot of time and potential momentum in a lot of these chronic diseases. And of course, the downstream effect is poor clinical outcomes, readmissions to the hospital, you name it. And so, you know, as an internal medicine physician, one of my biggest tools is prescription medications. And if I can't get and keep my patient on therapy, then I'm doing a big disservice to my patient and to the health system at large.
So, prior authorizations are often a problem both for physicians and patients. And for those who aren't familiar, can you describe what CMS has proposed regarding prior auths for prescription drugs?
Yeah, CMS is finally putting their foot down, if you will, to help move along the prior auth problem. And they're doing it through regulatory pressure and standards. So I think, you know, as we all know, as all the listeners know, prior authorization is cited as probably the number one cause of frustration, burnout, et cetera, among the clinician group. And so, about a year ago, there was a variety of payers who made a pledge to say, "Hey, we're going to help improve this prior authorization problem." And it was kind of like a pinky swear. I was very skeptical at the time, and I still remain skeptical. But a year later, CMS, I think, finally got a lot of the stakeholders together and said, you know, what can't be solved with pinky swears and promises, maybe we can solve with a little regulatory pressure. And so, just like they did 2 years ago to define a standards pathway for medical prior authorization, so think of needing permission for a MRI or for a particular surgery or procedure, they have now finally come back and done the same thing for prescription prior authorization. So they've set out standards, they've set out a timeline. The way this works is right now we're in a comment period. So they have proposed a rule, and anyone who is interested in influencing that rule or trying to, you know, move the needle a particular direction can provide a comment, a publicly facing comment. And CMS is required to read all of the comments and then, if appropriate, readjust the readjust the rule and then put it back out in the ether for another comment. So it's interesting. I'm very you know, if the pinky swear made me skeptical, this makes me very hopeful.
Does the policy go far enough? Do you think it will actually make a difference?
I do. I do think it'll make a difference. I think we've seen similar comments and proposed rules around interoperability and standards in the electronic health record space move the needle. I think for a lot of us, the needle doesn't move fast enough. I know that I've been in medicine for almost 25 years, informatics for 20 of them, and we're still talking about interoperability, which is a little crazy, but you have to remember you take the wins as you can get them. It's certainly a lot better than it was 10 years ago. I'm not going to doom and gloom this. But on the same hand, we still have fax machines. We still have reams of paper that we're dealing with. And so I think, you know, when the carrot and the stick, when the carrot doesn't necessarily work fast enough, then you start to use the stick. And that's what these regulations are ostensibly doing. One of the problems is that CMS only has so many levers that they can pull, meaning they can only truly regulate or influence the payers, the patients and the payers that they are responsible for. So think of Medicare, Medicaid, CHIP, for example. The private sector doesn't necessarily have to move along. They typically do because a lot of those big players operate in both spaces. And what I think in addition to this pressure, what I think we're also seeing is increased focus on this due to frustration from providers and patients. I think patients are finally getting so fed up that they are really leaning into this and voicing their frustration. And a lot of this gets amplified by social media and by um, poor outcomes that make the news cycle. A child who couldn't get their inhaler all of a sudden gets admitted to the hospital and eventually passes away. I mean, that's awful. And a lot of people will tie that back to how obfuscated this whole process is, how limited insight we have into the rules of prior authorization and approval. I'm very fond of saying this that the doctors and by proxy the patients are being asked to play a game, if you will, but don't necessarily know the rules to that game. So, imagine Final Four just ended about a week ago. Imagine, all you needed to do was get the ball into the basket. The ball is the medication, the basket is the patient. Seems simple enough, but oh, you just took too many steps. Oh, you didn't cross half court within 10 seconds. Go back to the baseline. Oh, the shot clock ran out. Well, I didn't know there was rules. I just thought I had to get the ball in the basket. And so what you really need is to couple not only policy, but also thoughtful decision support as guidance to the patients and to the providers, particularly to help them understand how to play the game.
You mentioned the comment period, and we hear that a lot with all the government rules, and I'm not sure people always understand what that is. If you're a physician and this is something you believe in, should you be sending in comments saying, hey, this is a great idea? Does that make a difference?
It does. They definitely aggregate and respond to the loudest voices, if you will. I think a lot of us as individual clinicians can work with other societies, the AMA, for example, or there's a group I'm a part of called the End Burnout Group. I'm sure they will submit a response as well. And then the key players in this will undoubtedly respond. So expect responses from the payer community. Expect responses from companies like DrFirst who play in this space directly. I think one of the things that is going to come out in the comment period is that the timeline of October of 2027 is very aggressive. And typically what happens is kind of like playing a game of chicken where, you bid high and then they bid low and then you meet in the middle. So I'm crystal ball a little bit, but I'm not sure October 27 is realistic. But that being said, we got to get something pen to paper so that we can get the momentum going.
What else needs to be done to make sure patients are adherent to their medications? It's not just a policy issue, is it?
No, no, gosh, no. There's so many, non-adherence is multifactorial. I like to say that there's kind of three buckets, if I wanted to generalize as to why patients don't pick up their medications. The first bucket is a financial bucket, right? Sticker shock upon arrival to the pharmacy, or not enough financial resources to necessarily fill all of your medications, so you start picking and choosing or splitting doses and things like that, which is technically non-adherence. And so anything that we can do to shed light on affordability for those medications, both at the provider and patient level, is critical. So things like at the moment of prescribing, does your system have the price benefit turned on so that you can see what the copay for that patient's going to be? And if the copay is, above $100, which is kind of this magic tipping point at the literature, you can have a conversation with the patient. Hey, is this something that you're going to be able to afford, or do we need to find alternatives, or do I need to help guide you to other resources like copay assistance or hub services for some of these drugs? So financial is the big one, and DrFirst is very proud of the fact that we put a lot of that financial data front and center, not only for the provider but also for the patient, to help empower them to go get these medications. The second one is what I would say is understanding or education. Patients sometimes don't really understand how important that medication is, or what the potential side effects are, or you know, why you can't necessarily skip days or split doses. They just don't understand. So how can we educate them to say, yeah, the first week might be a little rough, but after that, it's all going to be better. Those side effects, that nausea is going to go away. Because if they don't know that and they take it for 3 days and feel terrible, they might abandon it altogether. And again, I might not find that out for a year until they come back, and now I've lost that progress. And then the last one for non-adherence is life gets in the way, right? People just forget. People just, the thing is sitting out in the local pharmacy, and I didn't get it. So 2 weeks later, they put it back on the shelf. And so one of our solutions has ways to do thoughtful nudges to say, hey, don't forget to go get your medication. Hey, I found you some price support options. Hey, here's some education regarding that medication. And this is all personalized and delivered via SMS. And so I guess what I'm really getting at is one of the key things for adherence is patient engagement, and particularly personalized patient engagement. Some patients have different buckets that they fall into. And so, in this age of big data and even artificial intelligence, how can we make sure that we're personalized to the individual patient to get the optimal outcome, which is getting patients on and keeping them on therapy?
With all the promises of technology, as far as addressing the prior auth issue, do you think we'll ever get to the point where it's like an instantaneous, where the doctor puts in the drug and it immediately flags it as a like, hey, that's not in the allowed medicine? Do you think we'll get there, or what are your thoughts?
We're going to get close. We're going to get close. And one of the things in this rule is it's setting timelines for response rates, meaning like for that drug, or actually for all of the prescriptions that require a prior auth, you are required to provide me an answer within 24 hours, not a week, not, 2 weeks later, 24 hours. But I think we can be a lot more thoughtful and I alluded to this earlier, guiding the prescriber to provide the requisite information up front to avoid the prior auth. So we have our own data for particular drugs. You can actually avoid prior authorization simply by attaching the appropriate ICD-10 code. Well, I didn't know that. If I did know that, I would attach that code every time because I don't want to get the phone call or the fax later. And so that's that nod to the assistance that we can provide during prescribing. So I do think technology, this is largely solvable by technology. I do believe that. I still think there's going to be edge cases where you're going to have those peer-to-peer conversations for really complex situations and things like that that don't necessarily lend themselves to these deterministic outcomes. There really still is an art to medicine. It can't all be, point and click. I'm kind of fond of saying this about decision support is that the best decision support are like the lanes on a highway, right? I know I need to keep my car in between those lanes to arrive at my destination safely. But I still have agency. I'm still the doctor. If I need to do something different because it's the right thing to do, those lines don't stop me. I can deviate. I can get outside of those lines to go do the right thing. And so that's kind of that art of medicine that really can't be replaced by technology. Although, a lot of people think it can.
You mentioned a lot of different types of barriers for patient adherence. Are there some simple things doctors could do today to help their patients adhere to their medications more than they are?
Yeah, I think being very transparent. Transparency is the key. And the process, as I said earlier, is very non-transparent currently for both parties. A lot of times the patient assumes that I know, what what they can afford or what's going to be covered or what's going to be, require a prior authorization. And a lot of times we're flying just as blind as the patient until we get the phone call or the fax, a day or two later. So this is where technology and companies like DrFirst and other patient engagement solutions can really help. Um, so transparency, education, and I would say openness to have these conversations because sometimes these are difficult conversations to have with patients, particularly around affordability. A lot of patients might be too proud to bring up that they're never going to go get that prescription because there's no way they can afford that. It's that or groceries. And so, it's kind of removing the stigma around it because a lot of times there all are alternatives. A lot of times we can get creative and find different care pathways or connect with resources. And so it really is about a very open and honest two-way street between provider and patient.
Great. Is there anything else you'd like to add on this topic that we haven't talked about?
We've said a lot today, haven't we? I, I guess I'm hopeful. I'll go back to that, is that I was skeptical and now I'm a little bit hopeful, and I'm really excited to see what the next 60 days will bring as the comments start pouring in, and we'll really see where this thing lands. But this is the time when regulation actually, puts the foot on the accelerator a little bit, which only happens out of necessity in my experience. But it's an exciting time.
Very good, Doc. Thanks for joining me.
Thank you for having me anytime.